This session is being recorded. Thank you.
Hello, everyone. Thank you for joining us for our next session. My name's Abby. I use she, her pronouns, and I'm a third-year psych resident here at Yale and part of the organizing committee for this conference. We have live closed captioning available. Thank you to our transcribing team for their help. To access the captioning, please select Show Captions on your menu. If you have any other access needs, please let us know. A bit of housekeeping. This session is divided in two. And so the first session is about 35 minutes long with one presenter, followed by another 35-minute presentation with one presenter. And then after that, a break. We'll be hearing from the presenters first and then have time for Q&A at the end. As a reminder, please safely distance yourself for COVID purposes. We have a feedback form that we'll be sharing, so please be on the lookout. We'd love to hear from you. And then some discussion ground rules. Similar to the keynote presentation, please take space and make space for discussion. Use I statements when you speak about your specific experiences as opposed to using generalizations. And please be thoughtful in your storytelling. Avoid detailing specific instances of distress or violence, as this can be re-traumatizing to others. I'm thrilled to introduce our next session, which is titled Medicaid Prior Authorization for Buprenorphine as a Surveillance and Carceral Technology. And I'll let the presenter introduce themselves and we'll get started. Thank you.
Thank you so much for having me. My name is Max Jordan Nguemeni. I am a second-year internal medicine resident at Brigham and Women's Hospital in Boston. I'm thrilled to be here. I went to Yale for medical school, so this is like a bit of a homecoming for me. My presentation, as Ali just said, I will be talking about prior authorization forms for buprenorphine, specifically in Medicaid populations. I've been doing research on opioid use disorder for the last couple of years, and more recently I've sort of been focusing on this issue of prior authorization. So without further ado, I will work on sharing my slides. 1 second. Let's see. One second, sorry. View presenter view. Okay, oops, I am too far back. Okay, there we go. All right, can everyone see these?
Yep.
Yes.
All right. So I've already described the title, so I'll just jump into the background here. Just first of all, what are prior authorizations form, right? So there's sort of this bureaucratic mechanism used to make providers sort of justify the use of medications. And the reason why insurance plans use these is either to reduce overall cost of healthcare, or because of safety concerns and attempts at sort of reducing or preventing, quote unquote, abuse of certain medications that are either expensive or that are controlled substances. Now, there is a great deal of heterogeneity in terms of whether or not they are effective in ultimately reducing healthcare spending, and whether they conflict with other values like patient safety, patient autonomy, and equity and access to care. And so when it comes to opioid use disorder, buprenorphine is one of two mainstay therapies. Well, let me backpedal here. There are 3 FDA-approved medications for opioid use disorder: buprenorphine, methadone, and naltrexone. Now, if you ask any addiction specialist, they'll tell you buprenorphine and methadone are the 2 that actually have survival benefit or overdose prevention benefit, and naltrexone does not. With buprenorphine more specifically, the survival benefits are reaped immediately after initiation of therapy, whereas with methadone, there's a little bit of a delay because there's a period during which we're working on sort of titrating what is the most effective dose at which this patient is safe. And so it takes about weeks to a month for the survival benefits of methadone to kick in. Buprenorphine has been said to confer greater freedom and normalcy, but compared to methadone, mostly because of how we administer methadone in this country. People go to clinics and have to present daily. They have to take their medication under supervision, and they're often, being drug tested every time they present to the clinic. Until generic formulations of buprenorphine were available, it was a very expensive medication for health plans. And so prior authorization was used across health plans to contain expenditure and deter inappropriate prescribing. So if we quickly take a look at the history of treatment of opioid use disorder, methadone was introduced in the 1960s back in New York City during the then heroin epidemic. The FDA was overseeing the administration of methadone starting in 1972, and then fast forward about 30 years later, the FDA approved buprenorphine for OUD. And then 2 years later, 2004, state Medicaid plans began to cover buprenorphine. And then ultimately, sort of think about, it has become a mainstay, right? It's really picked up. And in the realm of prior authorizations, since 2018, CMS has issued instructions that Medicaid plans should limit the use of prior authorizations for buprenorphine and other medications for substance use disorders. And then around the same time frame, so 2018 to 2019, many states began to forbid private insurance plan from requiring prior authorizations for any substance use disorder treatments. This is, in line with issues related to our current opioid overdose epidemic. So as of 2020, 21 states had actually enacted laws that limit public and or private insurers from imposing prior authorization requirements for substance use treatment. And then in 2020, in light of the pandemic, which has further exacerbated the impact of the opioid overdose epidemic, the American Medical Association released a brief asking for a complete removal of prior authorization forms for buprenorphine. So, we talk about buprenorphine. It's the sort of active agent, but there are different formulations, and then it's sort of compounded in different ways. So I want to explain that a little bit because I'll go into further detail. So the most commonly prescribed formulation for opioid use disorder is buprenorphine naloxone in a sublingual film. Naloxone is supposed to be mostly inactive when taken sublingually, but it has at least a 10% bioavailability, so it's not entirely inactive. And the reason why this formulation exists in the first place, it's because when the U.S., basically U.S. government, NIDA, sort of the big actors were collaborating with pharmaceutical companies to introduce buprenorphine in the U.S. market, they asked, right, or in the sort of in the trial phase, they asked whether it was possible to deter people from injecting buprenorphine because in the 1990s, the mono product, which is just buprenorphine by itself, having been introduced in France, it was known to have a high street value. People did inject it for I don't know how to describe it. People injected buprenorphine, the mono product, in France. It had a high street value, but it is incredibly much safer than just about any other commonly used opioid, right? There's really no documented evidence of people overdosing on buprenorphine. sort of by itself. The very few cases that have been reported are people who are taking both buprenorphine and benzodiazepines, which are both respiratory suppressants. So from a harm reduction perspective, and injecting buprenorphine is far better than injecting other opioids in terms of reducing overdose risk. But in any case, the US government wanted there to be some kind of mechanism to prevent people from doing that. And so in adding naloxone to buprenorphine, such that if people were to inject the combined product, then they would immediately experience undesirable side effects. And it's true, it's been studied, people enjoy this far less than they do the mono product. But in any case, people still do inject the combined product of, buprenorphine. The flip side of this is that many patients report really unpleasant experiences with the combined product. Like, things that are often associated with opioid withdrawal, because again, even though naloxone has a low bioavailability when taken sublingually, that doesn't make it zero. And some people may be more sensitive to it. So they experience symptoms like nausea, stomach upset, itching, anxiety. And so for those patients, it really turns them away from buprenorphine in general, because it's not necessarily always explained to them like, oh, what you might be experiencing here, oh, it's because of this other agent that's combined with buprenorphine. Why don't we try another one, right? For a lot of people, they'll say, well, absolutely not. I don't want, and Suboxone or subs, as some people call it. They don't want it, right? Because they had the bad experience. They don't want to hear about even the mono product, because how do they know, right? It's not necessarily well communicated. Now, there are all these other formulations like the mono product that I was talking about, often more commonly used in pregnancy, although more recently it's been made clear that the combined product is also safe in pregnancy. There's a patch, there's an implant, there are tablets. All of these are more difficult to access, but they do have, again, fewer side effects because of the, there is no naloxone in it, and they're more expensive. So when I think about the impact that all of this has on patient care, right? So providers have listed prior authorization as one of the reasons why they're less inclined to prescribe buprenorphine, because it's sort of an annoying thing to do, to fill out a form and have to fax it or mail it, what have you. And on the AMA releases this report that said about 92% of physicians that they interviewed or surveyed reported that prior authorizations do delay care for their patients. They're also associated with lower retention in treatment and decreased utilization of buprenorphine. So as it makes sense, it sort of raises the activation energy for anyone to either want to prescribe it or through other ways that I'll discuss later. I can see how it may lower retention because of certain ceilings in terms of dosage, or mandates like, oh, well, you need to start tapering the dose, after a certain number of times that the patient's been on the medication. So, despite staggering evidence, state Medicaid plans continue to require prior authorizations, right? So it's been about 3 years now that Medicare, which is the insurance plan for older adults, and Medicaid is the sort of it's the federally sponsored insurance plan for basically either people who are poor or people who are not insured and can't afford private insurance, or pregnant people who don't have private insurance at the time of pregnancy and or in the postpartum period, which varies by state. Now, there are 32 states as of last year that require prior authorizations for at least one formulation of buprenorphine, and 15 of them, and all of them do require, all of these 32 states require a prior authorization for the mono product. That's the, buprenorphine alone without naloxone. 15 states require prior authorization for buprenorphine naloxone, which is the first line agent, right? Usually when insurance companies require sort of like a step therapy, like, okay, you have to try buprenorphine naloxone first, and if then the patient doesn't like it, or if they have some side effect, what have you, then we'll say, fine, go ahead and try the mono product because perhaps it didn't tolerate the other version. But even the first line agent, right? There are 15 states that still require prior authorizations for this. And I mean, and half of these don't, it's not a matter of preferred drug list. So in this case, insurance companies usually have a preferred drug list. That's to help reduce the cost. So cost cannot possibly really be the only reason why certain state Medicaid plans continue to require prior authorization. So we think about the impact or sort of the mechanism through how this sort of plays out. I've already talked about the bit of bureaucratic burden that usually is borne out by the providers, especially if they don't have sort of staff support, right? There's also an element of restrictive surveillance when you look at these forms. So in some states, the prior authorization form will have fields like requiring pill counts, random pill counts, random urine drug screenings, or that patients sign a contract with the provider related to their opioid use in general and other sort of illicit drug use. There are also these extraneous requirements, depending on the state where you look at, that basically create additional barriers to for patients, right? Some states will require that that a patient participates in like a 12-step group at a certain frequency or engages in psychotherapy, when the evidence makes it pretty clear that the medication by itself has a huge benefit in terms of survival. And so while therapy is helpful in terms of helping people build coping mechanisms and whatnot, should it be a barrier? Should it be a requirement before providing someone with a medication that is known to have huge survival benefit? And then there are things like dose limitations. So 11 states require additional steps for a daily dose higher than 16 milligrams. And a little bit of background here is that I think most people who are on buprenorphine for opioid use disorder are they're usually somewhere around 8 to 16 milligrams daily. But for people whose opioid use disorder is primarily driven by fentanyl or with really severe opioid use disorder, they may require higher dose. And so the sort of label, quote unquote, high dose buprenorphine, that's usually 24 to 32 milligrams daily. There is very good evidence that high dose buprenorphine is associated with also greater retention rates and decreased cravings, decreased odds that people will also use other substances. There have been studies where they've sort of compared patients who are on 16 milligram versus 24 versus 32, and they drug test them every so often when they come to clinic, and the patients who are on higher doses are less likely to have positive urine drug screenings. And then when you look at patient perspectives, it's clear that the barriers are annoying. I'm going to just read a couple of quotes from patients who participated in this qualitative study. The title of the study is "On My Own Terms: Motivation for Self-Treating Opioid Use Disorder with Non-Prescribed Buprenorphine." So it's because there is, it has a street value. People do just use bup on the street, and the majority of people who use buprenorphine that is not prescribed do so either to sort of self-treat their own opioid use disorder, or treat pain that is not well addressed, or treat withdrawal. So I'm going to read these couple of quotes. "You have to jump through the hoops with these damn treatment centers. No one wants to go. You can't work because you have to go to 3 groups a week and go to case management, see the doctor." And here's another one. "Therapy sessions or meetings could be used as a punishment for shortcomings like being late." And so all these barriers basically mean some people just opt out of, of sort of formal treatment in favor of an informal treatment, through the street drug market. But unfortunately, of course, this costs a lot more to patients when they're having to, buy this life-saving medication off the street because of barriers that are set up by our healthcare system. Now I want to talk a little bit about theory. This might be boring. So, Michel Foucault is this French, people call him sociologist, some people call him philosopher, sort of multidisciplinary scholar. He's these two notions, right? So biopower, which sort of refers to how institutions exert power to regulate life via disciplinary power. Like, for instance, prisons are a really good example of the state's exertion of biopower. And then biopolitics is how the state administers and optimizes the life of populations. So things like, I don't know, Medicare, or creating special circumstances such that people can access Medicaid when they really, when they, like pregnancy or the postpartum window. These are sort of examples of biopolitics in action. When we think about how all of that interacts with our system of addiction treatment, so Philippe Bourgois, he's an anthropologist who studies the methadone methadone maintenance therapy apparatus, and he's made it clear that through his studies that is sort of a hostile exercise of disciplining people, right? Sort of punishing people for quote unruly misuses of pleasure, and then controlling them as perceivably economically unproductive people. And similarly, when we think about buprenorphine and the ways, like how we've gotten to this point where, say, buprenorphine is the version that is that is more commonly used, that's the first line version, that's the one that insurance plans are covering more likely. It's sort of clear that there's an element of disciplining what is perceived to be an unruly misuse of pleasure, right? I didn't want to say it earlier, but basically, I mean, the reason why naloxone was combined to buprenorphine is because people aren't allowed to have fun, right? Like, because from a safety perspective, like, people are not going to overdose on buprenorphine, even though, of course, there are, skin and soft tissue infections that are associated with injecting drugs, if injecting drugs with either needles that are not clean or water, what have you. Now, in contrast, Shauna Harris, who's an anthropologist in Florida, who describes, based on her research, buprenorphine as a sort of symbol of freedom and normalcy, but that is very context dependent and unique to people who, one, already have easy access to primary care, have easy access to going to the pharmacy. Because in contrast with methadone, yes, you can pick up your buprenorphine. You can go to a doctor, I don't know, once a month, you get your prescription, you go to the pharmacy. So that affords people a sense of a bit of privacy. And it's very different from standing in line at a methadone clinic every morning, no matter how cold it is, and then taking a medication under surveillance. And Helen Hansen and team sort of describe or sort of further contextualize the meaning of buprenorphine if the patients at hand are poor, and it's considered to be sort of a potential site of abandonment because medications don't solve the underlying causes or reasons behind why people in the first place are experiencing opioid use disorder. They're often victims of brutal socio-political systems, or just victims of state violence. So taking all these sort of notions or positions around what buprenorphine versus methadone means, and what we know about how restrictive prior authorization, how the prior authorization system works, and especially that we're now at a point where it's been made clear that prior auths are not helpful. And if anything, they worsen outcomes, right? So why is it that the place where we're most likely to still see prior authorizations and the associated requirements of the process is in the Medicaid population? So I think what that means is that the combination of the evidence that has been made clear, the cost saving that actually comes from lifting prior authorization requirements, right? The state of Massachusetts did a study after lifting prior authorization requirements. There was a downstream reduction in healthcare spending. The fact that patients report having to, get buprenorphine off the street because of the bureaucratic hurdles, and the fact that the requirements include things like having to sign a contract with a provider, having to be randomly drug tested, having to count your pills or films and what have you. I think that suggests that there's an element of both control and punishment here, right? People who are on Medicaid insurance are disproportionately poor, disproportionately people of color, and state Medicaid agencies not lifting prior auth requirement while the evidence is staring them in the face, whether intentionally or not, basically are sort of producing a system of control and punishment of poor people who use drugs. There therefore is a bit of a conflict, right, between the state's aim to quote unquote optimize population health, which is the point of having Medicaid, the point of having Medicare, and its strong urge to discipline poor people who use drugs because of how much stigma as a society we hold against people who use drugs, especially if they're poor. So in this case, I think the sort of discipline and punishment urge ultimately overwhelms the state's population health aims. And this is sort of the conclusion here is that there is a need for state Medicaid plans to further be pressured or pushed towards lifting prior authorization requirements. I'm going to stop here. I think I've been going for 24 minutes and I want there to be enough time for question and discussions. So thank you for paying attention to my presentation.
Oh, do you have any questions? Or I have one. I was just thinking about on Barrington. I don't know if you can. Let's see. I can hear you. Okay, well, if you can see me wherever you are. I live currently a fourth year, or I guess now a first year CAP fellow, and I guess there's a lot of buprenorphine prescribing, and I don't know how it is in Massachusetts or here in Connecticut. I'm currently in Tennessee right now. I was wondering if you maybe have in terms of the different states. Have you seen any particular states that have legislature that make it a lot easier to get buprenorphine?
Yeah, I think Massachusetts is probably leading in that regard. So I was talking about caps in terms of like daily dose. The cap in Massachusetts before, or Mass Health as we call it here, before you have to sort of do more paperwork is 24 milligrams. Most other states that do have that cap is 16. So I'm a resident in a primary care track. So if I have a patient who have opioid use disorder, I do have the flexibility to easily prescribe 8 milligrams 3 times a day, which I just did like maybe 10 days ago in clinic, without having to fill an extra form out. And there is no prior auth for bup, the buprenorphine. But if I want to prescribe Subutex, unless the patient's pregnant, then I do have to file a prior auth. So I think Massachusetts is probably leading in that regard.
Okay. was wondering, and I guess I was wondering if you did any long-acting injectables. I know we do some of them. We're in Nashville, and I think for some people it works really well, but it's a select few. So I don't know if you've had experience with that, and just kind of put in some of the things in your lecture to like personal experience too.
Yeah, no, I personally haven't done, I mean, I don't have that big of a patient panel to start with, but I have not done the sublocade. I think that's what you're referring to. We have a bridge clinic, like, you know, in the hospital. I know they do long-acting agents there, but you know, eventually, like probably after residency, hopefully I'll sort of get some experience in that regard.
Very cool. I don't think we have any other questions. We appreciate your time very much as a video chat man.
Thank you. All right.
I just wanted to let y'all know that we have maybe like 5 minutes before you really need to get started.
Okay.
So if anyone wants to take a break, otherwise we can just power on through.
Okay, probably I'll take two to put up my PowerPoint. So should I start? Do you need some rest or should I start the presentation? Yeah, I'll start then. Thank you very much for being here. I am very excited because this is my first conference where I interact with people from the medical sciences. So I am very grateful to have the opportunity to interact and see what are the concerns on the other side of the aisle. I am a historian. I am a lecturer right now in the ethnicity, race and migration program here at Yale, and I teach courses about the history of public health. So as you can see, my concerns are more on social issues, are more on the role that the medical sciences have in constructions of the nation, race, etc. So I'm very excited to see what are your perspectives from the other side. And so my presentation today talks about the region of South Texas, which probably you know has an 80% Hispanic population according to the US Census of 2019. And you probably know this, but there is a big mental health problem among the Latino community, not necessarily because they have higher rates of mental illness, but in the sense that more than half of the Latino community has suffered from health disparities in access to mental health care and also in the quality of health that they receive. And this, the region of South Texas reflects these national trends, but I would say that it's a little bit worse in this region, which is more or less over here, because most of the population is rural population where health services do not arrive that easily. And also because it's mostly an immigrant population, many of them undocumented. So if they already have a low access to healthcare, their legal status sometimes makes it even worse. And this is not a new problem, really. Up until the 1960s, there were.
I'm so sorry to interrupt you.
I
You just need to adjust.
They
the
can't see it
virtual
online.
lines.
Sure.
I'm sorry.
So should I start again or okay? They could hear you, they just couldn't see them.
Okay.
Sorry about that.
No, that's okay.
Oh, I-
There we
Thank you very much. And sorry about that to everyone online. So I was saying that this is not a new problem. Up until the 1960s, there were only 3 institutions where the Latino community could go in the region. One, it was in Laredo, the other one in San Antonio, and the other one in Houston. Historians Alexandra Minastern, Carlos K. Blanton, and Miroslava Chavez Garcia have already noted that the only sustained contact that Latinos had with a mental health professional was through the psychologists who applied the massive IQ testing campaigns in public schools. And this is very problematic because these IQ testing campaigns legitimized eugenic policies of segregation, of incarceration, and it also they also justified anti-immigration policies, especially, I mean, this is the 1960s when the United States was trying to cut back migration from Latin America through the US-Mexico border. And so my presentation today focuses on a case study. It's a group of Chicano psychologists and Chicano leaders that, with the help of the Hug Foundation for Mental Health in Texas, opened an institution called the Zavala County Outreach Program. And this was very interesting because it was located in Crystal City, Texas, so very close to the border in southern Texas. And it was incredibly innovative because it had the collaboration of mental health professionals from UT Austin. There were also community leaders from the Chicano community. And what is more interesting is that it also counted with the collaboration of traditional healers. This was interesting because in the until the 1960s, traditional healers had been associated with the supposed Mexican cultural backwardness. They were associated with black magic and not with healing. So I started studying this topic because I wanted to understand what were the tensions, but also what opportunities it opened, this collaboration. And my presentation is divided in 3 parts, as you can see in the PowerPoint. The first part is in the 1950s and 60s, when a specialist from the Hug Foundation for Mental Health identified that, one, there was a big mental health problem in the region, but second, that this problem was furthered by the fact that Mexican and Mexican Americans preferred to use traditional healers instead of professionals, mental health professionals. The second part is about the community mental health movement in Texas and how this occurred at the same time as the rise of the Chicano movement, and how mental health policies became very politicized, became center of the Chicano debates about how should we achieve our liberation. And the third part is about the rise and fall of the Zavala County Mental Health Outreach program. So I'll go with the first part. And this story, starts when the Hug Foundation for Mental Health published a series of news stories and documentaries that exposed the very bad conditions in state asylums and also the mistreatment of patients. And the Hug Foundation did this with the purpose of prompting the state government to reform mental health care and to create some system that helped former patients to reintegrate into society more easily. And so I start here because as a result of these documentaries, specialists started to analyze, okay, so how would this reform look like? What kind of populations we should address the reform, and what kind of services we should promote or provide. And they found something very interesting. They found that, so first of all, mental health professionals were convinced that mental illness affected a specific type of population. It was a population that came from broken families, that came from complicated pregnancies, that they had low levels of education, lived in crowded households, or they were in families with working mothers. So you can see that there was already a cultural and racial bias there. And they identified that the populations who fit this description were generally African Americans, Puerto Ricans, immigrants, and the poor in general. So by this definition, they expected already that the Mexican and Mexican American population would present higher rates of mental illness. But the surprising thing was that when the Hug Foundation commissioned this epidemiology to psychiatrist Lee Jacob, he actually found that the Mexican population were the most underrepresented population in both public and private institutions. So he started thinking, why is it? Because actually they do not have many mental health issues, or they deal with them in their homes or more effectively. And essentially what he suspected is that it was a big problem, like every epidemiologist expected, but that instead of going to the professionals, they went to, they used an underground system of folk medicine practiced by curanderos, witch doctors, herbalists, and other subjects. And that these healers were so well respected that that even when they died, they sanctified these healers, like is the case of Don Pedrito Jaramillo, who was a Mexican-born healer. He moved to the US in the 1930s and became very famous. There were lines of people outside his home waiting for him to give him consultation. Right, so the specialists, which were a combination of anthropologists and also sociologists, psychologists, they analyzed this phenomenon. And they found that because Mexicans deal with their mental health issues in a more spiritual framework, they had a completely different system of classification of disease that combined elements of humoral medicine with elements of religiosity and also supernatural explanations for disease. And because it was in a spiritual framework, the treatments included prayers, included rubbing eggs throughout the body to take the bad energy, herbal remedies, pilgrimages, asking for forgiveness to a person who you offended, etc. And according to anthropologist William Madsen, a Mexican American may even doubt the physician's knowledge of natural diseases. This is a quote. He points out that a curandero knows how to treat a patient, but a physician has to consult books, colleagues, or rely on x-rays to discover the cause of an ailment. A curandero petitions God and the saints for aid in the cure, but a physician generally ignores the possibility of the divine help. As one Mexican American put it, doctors act as though they know better than God who created them. So in my research, I studied how scientists look at these practices and how they portray them, as I mentioned at the beginning, as a symbol of the Mexican cultural backgrounds, as a symbol of how preserving these cultures could be damaging to the community's well-being, right? But when you study these individual cases with and compare it with the context, specifically the fact that there was only one psychologist speaking English in the region, that there were only 3 institutions available to them. When you combine that with the historical legacy and relationship between psychology and eugenics, you can easily understand why these populations preferred traditional medicine over mental health, professional mental health, right? By making this comparison, we find that actually traditional medicine gives us something else that mental health professionals weren't able to offer. And that was affordability, that was availability, right? That was that for the one psychologist who spoke Spanish in the region, there were dozens of curanderos who could fill these gaps, right? We have that curanderos validate Mexican culture, especially in a hostile environment, right? When they are forced to assimilate into American values. And we find that also that curanderos went to the patient's homes instead of waiting for the patient to come to them, right? And most importantly, they took other roles that went beyond healing. A curandero could be an intermediator between, in any family conflict or community conflict. They act as confessors sometimes. They help their patients get jobs. They help patients to connect with the community if they were new there. So they took all these other important roles. And because they play such an important social and cultural role in community, anthropologists like William Madsen, Arthur Rubel, psychologists Sally J. Andrade, and psychiatrist Fuller Torrey, they were prompting the Texas state to incorporate curanderos into the official mental health care system, at least in a transitionary role. The idea was that New York was already doing it with spiritists, and this was to attract the Puerto Rican community into the institutions. And that was proven to be very effective in New York City, at least. So they wanted to do something similar in Texas. And the idea is that while curanderos would be able to fill the gaps and would be able to offer a culturally relevant service, they would also be able to teach mental health professionals about Mexican culture, about Mexican religiosity, and most importantly, they would help mental health professionals to improve their image with the community and kind of divorce themselves from this history with eugenics. So they saw a lot of benefits in doing it. But these proposals were not followed up. Why? Because historian Jennifer Kostaka has a great book, if you're interested, where she analyzes the portrayals in newspapers and in scientific articles. And as you can see, I mean, the portrayals about it were pretty dramatic, right? They did not recognize curanderos as healers. They rather saw them as religious figures, right? So that leads, and another example of a negative portrayal comes from sociologist Charles Maysgayer, who even said that curanderismo was a contributing factor to the high rates of intellectual disability among the Mexican American population. Why? Because when a Mexican person had some emotional issues, they didn't go to professionals, they went to curanderos who made the problems worse. And then to the point that the emotional distress or illness became pretty much impossible to deal with, right? Yeah, so that leads us to the second part of my presentation. And that's when the state of Texas applied for a community mental health grant. I'm probably you don't know, or you do know what is the community mental health movement. But the idea of this federal policy was not only de-institutionalized patients, which is what it's known for more popularly, but also to expand mental health services to underserved communities. Texas was one of the first states that applied for a grant, and Texas got it in 1965. Sorry. By 1967, Texas managed to open 27 community mental health clinics across the state. But this is something interesting. The state created the Texas Department for Mental Health and Mental Retardation that coordinated all the efforts. But there was a bias in the kind of services that they offered in each population. So I think I didn't brought it, but normally in urban centers, they offered comprehensive services, but in rural areas, so first of all, there was nothing here, right? But in rural areas, what they did is to rather create mental retardation centers. And this was a kind of special education centers, but that also offered diagnostic services, talks to the parents about how to deal with intellectual disability, about what opportunities kids have. So you can see that even though the massive IQ testing campaigns stopped by the 1960s, these associations of Mexican culture with intellectual disability continued differently. Maybe not so much in racial discourses that talked about biological differences, but it was more based on cultural discourses. Yeah, so why this bias? Why did they stress mental retardation? That's the term of the time. By the way, it's very problematic right now, but that's those are the concepts that were used in the 60s. And so why intellectual disability centers in rural areas? That's again because sociologists like Charles Maysgeyer maintain that intellectual disability disproportionately affected Black and Mexican people because both populations fit with the profile of culturally deprived populations. Both of them were concentrated in areas tending areas tending toward little industrial and economic development, meaning rural areas. They have higher rates of unemployment. Their salaries were half than those received by Anglos, and the proportion of illiteracy was 4 times greater than in Anglo groups. In the case of Mexican descent populations, the cultural deprivation was even more because of their language handicap. And I mean, I have the quote here, very problematic, right? So you can imagine that in the eyes of Mexican Americans and Chicano youth, all of these interpretations were incredibly troubling, and especially because they legitimized the school segregation of Mexican children into special education programs, which there are arguments that special education programs often serve as pipelines to the carceral system, right? And they view this policy as a strategy to force children to assimilate into American cultures, and especially the vocational programs as a strategy to segregate Mexican populations into manual labor, meaning to continue in the farm work as farm workers, right? Not as professionals. So since the 1940s, Chicano activists have warned about this, and they have complained about the racialized interpretations. They have asked for change, but the Texas Department of Health hasn't gone, or at least until the 1960s, didn't do anything. So finally, in 1968, all of the tensions surrounding intellectual disability and the complicity of the school system with the criminal system as well exploded. And in December 2nd of 1969, 2,000 students were mobilized by a Chicano activist, organized a student walkout in Crystal City High School. So this is interesting because the protest against the eugenic interpretations of intelligence and Mexican culture were not necessarily targeted to the Texas Department of Mental Health and Mental Retardation. These protests took place in the schools because these were the centers where most children were diverted into the mental retardation centers, right? Intellectual disability. Right. And so in this student walkout, the students complained that it is not the low performance of Mexican students in schools was not because of a matter of intelligence or culture or language. It was rather a matter that there were only Anglo staff in the high schools, that Mexicans were often penalized for speaking Spanish at schools. Most of the curriculum was generated to reinforce Anglo culture and Anglo values, and that Anglo students had preferential treatment over Mexican students, right? They also complained that even in schools, not necessarily special education, but the regular ones, they were persuaded to take vocational programs. So women, female students would go into something called home economics, where they would learn to cook and take care of their families. And the boys would learn manual labor. So it's a reproduction of the same system also there. And a year after the student walkout, the same activist pushed the local school board to create a dropout prevention program led by social psychologist Sally J. Andrade. When she arrived to Crystal City, she was shocked because even though the Texas State Mental Health Plan labeled Zavala County as one of the high priority areas, there was no mental health institution nearby in kilometers or miles in the American system, right? And for her, this was pretty severe because of these political tensions, there was an increasing hostile environment towards them, and there were actually violent attacks, racially motivated, attacks against Mexican students. And so she believed that it was necessary to do a mental health intervention program, not so much to contain this protest or to correct their behavior, but it was more to offer Mexican students support on how to cope with the hostility coming from outside, and how to do better in school despite the obstacles, right? So what they did, was Sally J. Andrade and her supervisors went again to Wayne Holtzman, a psychologist who was then directing the Hug Foundation for Mental Health, and asked for funding to create a pilot program of culturally competent mental health services for this community. Wayne Holtzman, he had a lot of connections in Mexico, so was very interested in the topic and approved the funding, approved $35,000 for a period of each year for a period of 5 years. And thanks to this funding, this activist could create the Zavala County mental health outreach program, which leads to the final part of the paper. So this program was unique since the beginning for a few reasons. Not only because it had these collaborations at multiple levels, professionals, community leaders, traditional healers, but also because it directly challenged the biases of intellectual disability services versus the comprehensive mental health services. Yeah, and also because, as I see it, it offered a promising alternative where mental health workers could deal with the issues not at the individual level, but at a social and more structural level. And also it was a project completely managed by the Chicano community themselves. And this was because since the Hawk Foundation is a private institution, they had a little more liberty on how to experiment, right? And so during the first months of operation, you will find interesting because all of this you are seeing in the PowerPoint, it seems like unrelated to mental health, right? They were doing this home court program where they went to the residents' houses, they helped them cook, they helped them do groceries. They also bought a van to provide transportation to local doctors or hospitals nearby, or even to welfare institutions. They helped the residents to apply for food stamps, for welfare services, and they also offered this drug and counseling program. But even though this seems completely unrelated to mental health, they combine these with visits from psychologists and psychiatrists from UT Austin who diagnosed the resident if they had any issue and also provided medical treatments. So I really like this case study, and the reason why I focused on it is because it's very telling about how this embodied the ideals of the community mental health movement, being that mental health services should be designed surrounding the community's needs, that they should tackle the problems of mental illness and mental health from a social perspective, right? Another ideal is to diversify the healthcare system, to make it more culturally relevant to diverse populations that the US is composed of, right? And simultaneously, this program in some ways appropriated the philosophy of folk medicine, traditional medicine, in the sense that they didn't have to do the rubbing the egg over the body or herbal remedies, right? But they they appropriated ideas of taking responsibility for the community's well-being, not just the patients, right? Making healthcare easily accessible to people, making it a positive experience for the patients, make them feel comfortable, make them feel like the health worker understands what they are going through, understanding the social problems, right? But unfortunately, this project failed very quickly in 1977 because neither the Hawk Foundation nor the Department of Health in Texas could really measure the benefits that this program brought to Crystal City, because it didn't provide results that could be measured or could be observed in the people's behavior. The results were more about community building, were more about their community formations, right? And so since the mid-70s, both the Hawk Foundation and the state of Texas attacked the program and criticized it for different reasons. One is that the goals were so ambiguous that the program was more like a catch-all, more an umbrella for any kind of support to people, right? The second critique was that even though the professionals said they were positively surprised by the militancy and the political involvement of their members in the Chicano movement, they were very concerned that by supporting it too much, they would reflect some alliances with a political party or with a political movement, when the role of scientists is to remain objective, to remain neutral to what's going on in society. The third critique is the lack of professionalism, because most of the only criteria to join the project as a mental health worker was to answer 3 questions. The first one was, do you like to work with the community? The second one was, are you willing to give more than your work time hours to make this work? And the third time is, do you like to work as a team? So many women who were unemployed in Crystal City joined, and they became the health workers. They were so overworked that it was very difficult for them to catch up with so many patients. And not only they were overworked, they also didn't have a training on how to deal with emergency crisis. And they even, the evaluators even gave an example of a health worker who died by suicide because of the stress of the project in her life. And the last critique was poor record keeping. And I mean, this is understandable because they reported at some point that they had something like 5,000 high schoolers, right? It was too many patients for so few people. So what happened? In 1977, the Hawk Foundation for Mental Health sent a letter to the directors saying we cannot continue our support to you because of all these reasons, lack of record keeping, etc. This devastated the community because many members depended on the program to do their groceries or to ask for food stamps. And at some point, they even sent letters saying, the program has helped me with this. I cannot live without the program. Please maintain it alive. But the Hope Foundation decided not to continue it. And because they depended so much on the Hope Foundation, they ended up closing, especially because the health workers, there was no evidence, but the health workers believed that the state of Texas was blocking their review process and making a lot of more demands over time. So eventually the Zavala County program was absorbed by the Centro de Salud that was nearby. And the Centro de Salud had a much more biomedical approach. So many community members who were not diagnosed with a particular disease, they lost the support they had. And they didn't want to go to the Centro de Salud because of these still associations with eugenics, with intellectual disability, right? So with this historical case study, I hope to show that for historically marginalized populations, treatment is most effective when this biomedical approach incorporates cultural and community-oriented measures that often traditional medicine offers, right? However, as the Zavala County project illustrates, the benefits of this combination of social and biomedical are very difficult to identify, especially if you try to identify under biomedical standards, right? Which is the case here. So I hope that with this case study and continuing my research, I can explore some spaces where there is collaboration between social scientists, people in the humanities, right? Who could offer this view of the benefits, not from the biomedical approach, but more from a social and cultural one. And so that's my presentation. I really thank you for being here and for paying attention to the presentation. And I'm open to your questions, comments, warnings, whatever. Thank you very much.
You go ahead. Mine was just a comment. Well, first, thank you. That was really excellent presentation. Just a comment that I think I had seen some kind of presentation on television about a similar thing happening with students in the UK, particularly students of color, students that were poor, being funneled into these separate schools. That happened in other places. I was interested to hear that it happened in Texas as well. Unfortunately, and I love I love hearing about that. Even though it failed, there were so many exciting potentials there with the social, with more of a social model of mental health and community support. So thank you so much.
And I would say that the failure is a little more relative because many of the women who entered as health workers to this program became psychologists later or social workers. So became professionals, and they were the activists who then included the feminist critique to the Chicano movement. So I think in some ways, even though it failed in the sense that it closed, it really empowered the population in ways that, I mean, a mental health professional could not see that easily. So thank you very much for your comment.
Yeah, just echoing, this was a fantastic presentation, and I think just such an insightful case study that it was very clear to see how things can be applied and how this model has been sort of recapitulated in other contexts and what it can teach us. And so one of the things that sort of stood out is that this more social focused model of approaching mental health definitely had benefits for people, but there were just issues of legitimizing in the context that that they were in. Do you have any advice for how one can go about measuring these really difficult to measure parameters? Because they are, I mean, I think they, as we've seen, they are helpful, beneficial, and needed in today's space. But it again, when you're thinking in the context of grants, when you're thinking in the context of approval, it's a hard thing to quantify.
Yeah, I think echoing what Max presented in his own talk, I think the key to identify the benefits from a more marginalized perspective is to listen to the patient's testimonials, to listen, and that's what they did, to listen to what do you need as a community. Maybe you don't need psychopharmacological treatments, at least not much of it. They needed transportation, they needed help with taking care of their children. So I would say that bringing the patient's voice is one of the ways that you can ensure to respond to these needs, but also by bringing that voice, you can kind of sense if they feel satisfied with the service or not. So I would say that's one. And the other one that I have tried to do by joining the ER&M program is to also facilitate education in issues of race, issues of culture, offering courses that are open to medical students, to people who probably are not that familiarized with this debates and discussions. So I would say those two. But in terms of how do you quantify that for a grant application? That is, I think, the harder challenge that I do not have the answer yet, but probably when I am more advanced in my career, I will have one.
And I just wanted to chime in. I actually work for a Yale program for recovery and community health,
Mhm.
Yale Perch. And I don't know if any of you got the chance to go to the Nguemeni breakthrough sessions that was offered, but they do a lot of participatory research and qualitative research. So that's one way, and they do beautiful work around that. It really is about community and culture and about the people experiencing
Yes.
the services guiding what they need, so. there's some
And
good-
yeah, and something I was also forgetting is that one of the main priorities of Chicano psychologists at the time was also to democratize the mental health sciences. Because it was not, if you didn't have that population representing those interests in the sciences, then how do you expect to respond to other people's needs? And so they were doing, that's out of another part of my research, but they were doing a lot of affirmative action programs, recruitment, teaching students what is psychology, how do you get into it, what kind of jobs you can get, etc. So yeah, thank you very much for your question. Yes.
My name is Alex, that's terrific. I'm a resident in internal medicine in New Mexico. So we have it's really like that kind of South Texas, like Chihuahua bordering kind of area. That's like, those are my neighbors, right? Like that's who we see in the hospital. But there's this really weird thing that kind of comes up that like, we talk a ton about culturally competent care for other folks, like namely people from Navajo Nation and like the Dene group, but for the Pueblo people, but we don't talk at all about Chicano folks, like kind of the history for where that's at like today. And I'm Googling, apparently my university has some sort of like course, but it never trickles past. And so I'm just kind of like feeling, ignorant. But curious, like how does that kind of thing like evolve? Because it doesn't seem to have made its way into kind of the integrative medicine conversation in the same way that kind of maybe more traditional Eastern stuff like acupuncture has. Like where's all that today, do you feel like?
Yeah, definitely. So I see, first of all, curanderismo is still very popular among Latino communities. I think the elements of curanderismo that have been more legitimized in the health sciences right now are those that have to do with herbal medicine, right? Not so much those that are more spiritual and religious. So I think those are still marginalized, but still very popular. There is actually a very interesting case in New Mexico of another curandera, and this just shows, right, how even still today the way our attitudes towards traditional medicine are very filtered by notions of race and gender, right? Because there was another case of a curandera in New Mexico and Arizona, I think. She was very accepted in Anglo groups, but she was accepted as a performer of, electric medicine. It was more exotic. She was exoticized a lot, as opposed to Don Pedrito Jaramillo, who was posed as a threat to the nation, as a threat to the individual's well-being. So I would say that those debates about curanderismo are still change over time, depending how issues of race and gender are solved, but definitely still marginalized, I would think. And what is interesting is that after the COVID pandemic, there was a revival of traditional healing and herbal shops, botanicas, because, obviously the political context, but also because lack of health insurance. For some people, this form of traditional medicine is the only option they have to access healthcare, at least sustained healthcare. So yeah, I don't know if that answers your question,
Yeah.
but thank you very much.
Thank you to everybody. We're unfortunately at time, but thank you so much for your presentation. We have a break for coffee or whatever else, bio break until 3:30. The coffee will be back in the original area that the keynote speaker was at, so the Harkness Auditorium. And feel free to come back here early and we'll start again at 3:30.
Yeah,
So thank you, everyone.
and thank you very much for the organization and all the efforts.